So we will go ahead and kick things off. Hi, everyone. I'm Emily Killo. I'm a child abuse pediatrician at Children's Mercy in Kansas City, and I'll be your facilitator today. And we will start off with introductions per usual. We'll go around the room. If you have access to a camera and a microphone, turn your camera on so we can see your face. It helps us all get to know each other. And if you don't have a camera or microphone, that's okay. You can put your intro in the chat as well, like Amanda has done. Thanks, Amanda. So I will have Allison, you're up first on my screen, so I'll have you go, and then Lane can go next, and Lane's going to be our presenter today.
Sure. Lane, if you want to go ahead and stop sharing until it's time for the presentation, that way we can see everyone's face when we're introducing.
Sorry about that. Yes.
No, that's totally fine. My name is Allison. I am the Echo coordinator for this Echo. If you have any questions about getting access to SharePoint, where we house all of our cases and presentations, I will put my information in the chat. I can also answer any questions about any of the other 34 Echoes that we offer. So thanks for joining today.
Oh, sorry, I was next. Spaced out. Okay, so I'm Lane, and I am a child and adolescent psychiatrist, and I work at the University of Missouri in Columbia. Um, I work for the university for the department, but I also am a kind of the director of our Center for Child Wellbeing. So,
Thanks, Lane. Jill and then Claire.
Hi, I'm Jill Pingle. I'm with the Missouri Children's Division. I'm a unit manager in the Health Information Specialist unit.
Hi, I'm Claire Hickey. I'm a general pediatrician at Children's Mercy in Kansas City in the foster care clinic.
Oh man, I'm falling down on my job. How about Jamie and then Karen?
Hey, I'm Jamie Scacia. I'm a clinical psychologist at Family Forward in St. Louis.
Hi, I'm Karen Bickle. I am a legal aspects trainer and attorney for Children's Division.
Awesome. Carrie, you're up next, and then Clark. I'm trying to track all the ones in the chat.
Hi, everybody. My name's Carrie Deinhardt. I'm a child and adolescent psychiatrist, and I'm the medical director for Show Me Healthy Kids, which is the specialty health care plan for children in foster care and on adoption subsidy for the state of Missouri. And I'm also the Friday consulting doctor for the Missouri Child Psychiatry Access Project.
It's Clark Peters. I'm sorry to say I'm in a car, so I'll turn off my microphone and camera in a second, but glad to be here. I'm a faculty at the School of Social Work at Mizzou.
Awesome. I
So
was
now,
going to say, drive safely, Clark. I can see. Yeah. Thanks for joining. Appreciate it. Okay, I think I have everyone else's intros in the chat. So Phineas, Dylan, Amanda, we have yours, Garrett, Jan, Madison, and Catherine. So thank you everyone for being here today. Thanks for putting your info in the chat. And just a few reminders as we are getting things started. Again, if you have a camera and you're not driving and it's safe, turn your camera on so we can see you. If you have a question or a comment at any point, you can put it in the chat and we will definitely be monitoring that and get to it, or you can put your little hand up using the little emoji thing on the bottom and we will call on you that way as well. Otherwise, try to keep your microphone muted just so that it minimizes background noise. And our agenda for today is that we are going to start off with Lane's presentation on problematic medication use in the foster care population. We'll have time for questions and discussions. We don't have a case submitted today, so if anyone has a case they'd like to discuss, or if this presentation spurs you to think about a recent case, we would love to hear from you. So I'll kind of pause after the discussion from the presentation is done to see if anyone has come up with thoughts or questions, and we'll all be thinking too. So thanks again for being here today. And I see Maya hopped on. Maya, you want to introduce yourself really quickly before we start the presentation?
Yep, sorry. Finishing clinic as usual. Maya Moody, community pediatrician in St. Louis, Missouri, in a safety net clinic.
Yeah, I know you got to get things wrapped up before you jump on. So glad you're here. Thanks so much. Okay, Lane, we will turn things over to you. Thanks so much.
great. Okay. So, this is a presentation that has been done before. Some people may or may not have heard it, but my opinion was that even if you have heard it once, it takes, I think, for the adult 3 times of hearing something to really incorporate it into your psyche. And you pick up different things each time. And I didn't realize, Emily, that maybe my presentation would be a spurring of case, discussion. So, things happen for a reason. I will go through this, but I'm the type of person that is totally okay with you stopping me while I'm talking if you have a question, and not feeling like you have to wait until I get to the end. Okay, so, and let's see if I can make, there it goes. So there was a spotlight that was kind of placed on foster care and psychotropic use from really a kind of terrible experience of a little boy in Florida named Gabriel Myers. And so I'm going to give you a little bit of that background, also then talk about how that shaped some nationwide action, and then talk a little bit about Missouri and Missouri's role in this. So this little boy was born in February of 2002, and shortly after his birth, CD got involved because there was a positive drug test involved at the delivery. And so then also they continued to be involved as they found out that she was doing things like, bathing him in cold water, and just the care of him was not what it should have been. So early on, they did place him with his grandparents. So there was a temporary custody placement there while there was an attempt to work with the mom and get him back with the mom. He did go back to his mom where he was exposed to her drug use. And at times he was with her while she was unconscious and drugs were all around. And so eventually at age 6, so, after 6 years of this type of exposure, he was removed from mom's custody. And at that time, he was already on one psychotropic medication, which was Adderall XR. And at 6, he was giving himself his own medication. It wasn't being monitored necessarily by an adult in the room. So prior to him dying, he had moved from one foster home to another. He had actually also been in a residential placement. And there were some reports during that time of him having bruises on his bottom from being paddled, of some sexual inappropriate behavior and abuse by other children in a foster home, and then of him having some sexually inappropriate behavior with girls. So over the time he was in placements, other medications were prescribed. So he had been on Vyvanse, which is also a stimulant. He'd been on Lexapro, which is an antidepressant / anti-anxiety medicine, and Symbyax, which is a combination of like an antipsychotic and an SSRI. So just so you know, I see through my work at the center kids on even more medication than this, right? But even this was a challenge. So he was 7. So I told you he was removed from his mom's custody at 6 and was placed in different foster homes and residential. And a year later, he was found hanging in the home of foster parents in Florida. So there was a work group that was created to review this case. And the things that they found was that there really needed to be more oversight with the foster care population and mental health treatment, psychotropic prescribing. There were lots of issues that they addressed. These are some, not all of them. And I have to figure out how to make my box smaller so I can see you all. Hold on a second. Is the presentation still there for you?
Yep.
Yes. Okay. Let me try to figure out how to do this. Okay. So some of the issues, and some of these are also seen in Missouri, but, the sharing of information. So a kid is in one hospital and then goes to another, or sees one provider and then sees another, and the information sharing between all those providers was problematic. Also, accountability of who needed to take charge, who needed to be the decision maker, who needed to make sure these things were happening, was not there. I mean, individual and agency accountability was a problem. They were labeling the behaviors that he was having as sexual behaviors. And, with that, I think if we work with kids, we all know that when that happens, sometimes it stigmatizes that youth. And then you're only looking at their sexual behaviors towards others and not thinking about what's happening to them that is probably spurring some of those behaviors that they're having. Identification and screening and assessment of behaviors was challenging. And then really ensuring that best practice was happening with this kid along the way with all the people he was seeing was not occurring. So in 2010, the work group issued some recommendations related to using psychotropic meds in children in foster care. Subsequently, after that, and this was at a time when I was the Associate Medical Director at Department of Mental Health for the state of Missouri. So in 2012, there was a federal call for all states to come together in Washington, D.C. for a meeting where you would bring Department of Health and you would bring mental health, foster care, and Medicaid together. So we had a representative from each of those areas that went to this national meeting. And the goal was really to look at this problem of oversight of psychotropic medications and to develop a plan. And for each state to hear from other states what they were doing, to hear what might be best practice, and then to develop their own plan. So we did that, the three agencies together, and we had multiple initiatives that had been going on for a few years before the lawsuit happened in Missouri. So one of the things that I want to really touch on is just in general, what are some of the challenges with psychotropic use in foster care? And this is nationwide. This population has a higher prevalence of use of psychotropic medications compared to the population not in foster care. There's increased use of polypharmacy, so 2 or more psychotropic medications. There's the potential for overprescribing. So there's a kid, he's in a foster home, he gets aggressive, he acts out, he goes to the hospital, a pill is added. And a lot of times pills are not reduced, they're added. And for every time there's a behavior or an issue, there's more and more prescribing. So that potential is definitely there and a reality of what happens. And also consent and oversight have been challenges. So there's an actual study in JAMA, and I, at the end of this, have my references. So if you want to pull that up and look at it, you can. I went back since I did this presentation last year and looked at the literature to see if there's any compelling updates or things that were different, and there really weren't. So I'm using the same data from the past. But as I said earlier, psychotropic medication use in the foster care population is higher than the general population. So there's a wide range between 13 to 52% difference in foster care of use in foster care versus 4% in the general population. And then that study in JAMA showed that about 26% of kids in foster care had a at least one psychotropic medication prescription compared to 9% of other use on Medicaid. So you can see that's over 2 times as much. And the use in general is, it's a wide range, 13 to 52, but even at 13, that's, 3 times as much. So if you look at the types of medications that are used in these youth, it's stimulants are the highest at 16%, and those are typically used for ADHD. Antidepressants are next at 10%. And those can be used for depression, but also for anxiety. And then antipsychotics at 8%. And this is the area that I get really frustrated with because it seems as if, to me, a lot of times if an aggression behavior occurs, an antipsychotic is used. And there's a lot of times, I'm going to try not to overgeneralize, not a willingness to go back and look at what is causing the behavior and what are some non-pharmaceutical interventions that we can use that may address the behavior. And I would say my belief in general is that meds are seen as a quick fix, right? For a problem that may or may not always necessitate a medication. So 43% of youth in foster care and this is that study that's going to be cited later, have been diagnosed with a mental health condition. Most commonly, it's a trauma or other stress-related disorder or ADHD, and those are pretty close, 23% versus 22%. There's also behavior or conduct disorder at a 12% rate. So, as I said earlier, the Department of Health and Human Services had that meeting in 2012, and the initiation of it was the Gabriel Myers event, and really the national spotlight on this issue. We did send from Missouri 3 representatives. I think for Medicaid, it was Dr. Joe Parks. For mental health, for Medicaid, it was not. He was not the director at that point. For mental health, it was me, and then foster care, I cannot remember, but it was the directors of the different areas. And as a state, we really actually had some things we were already doing for general population of psychotropic use, but we honed in on some more initiatives we could use that were tailored to foster care. And we did see some positive momentum in that first 6 years, but it was small, and it obviously needed to go a little deeper, higher. So Missouri's response was kind of accelerated with the lawsuit that happened, where there was several named children, and saying that oversight was an issue, and there were multiple other areas of concern. And so when that happened, one of the things that Children's Division did was to enter into a contractual relationship with the University of Missouri in Columbia through a program called MoChild, right? And that program has been, you probably may have heard in the past, Center for Excellence was what it was called at some point, but it's the Missouri Children's Health Integration Learning and Development Program. It is called MoChild, not Center for Excellence anymore. And the reason for that name change was confusion that came about when an actual Center for Child Wellbeing was created in 2024. And so some of the areas of focus for that work was around informed consent and mandatory reviews of children who meet quality indicators, which I'll talk a little bit more about, but then also kind of reviews that could occur to help Children's Division when they had questions about whether a medication was appropriate or not that a prescriber was trying to use. And so early on, there were a lot of education. There was a webinar created about informed consent and what that is. And it was presented to the workers at Children's Division so that they would have that information. There were also some webinars about medications to help them have a better understanding about stimulants and what they were and what they did and what potential side effects existed, about anti-anxiety medications, antidepressants, and antipsychotics. And really just a lot of engagement. So this work with MoChild is not MoChild working directly with a patient or even a provider, but it is the support that MoChild provides to Children's Division so that they can feel comfortable with decisions that they make about informed consent, so that they have information about children in their care and custody that may be on 2 or more antipsychotics, 5 or more psychotropic medications. If they're young in age 4, then those thresholds are even smaller. So the things that MoChild is doing are on the spot. The kid isn't on medication, but a doctor is requesting that they start it. Children's Division hopefully would be comfortable with making that decision based on some of the education and things that have been provided over time. But if they have a question and they want a clinician to give them guidance, then they can send that to MoChild to review that and then give Children's Division feedback back about, is this an appropriate medication? Does it make sense? That kind of thing. The mandatory reviews, they happen on a monthly basis, and there are certain quality indicators that are identified that are looked at. So they're not kind of in the moment. These kids are already on the medications, but they hit a quality indicator, which requires them to be at least reviewed to determine, is this best practice, and are there different recommendations that a clinician would recommend for the medication treatment. The second piece of that was the Psychotropic Medication Advisory Committee was established. That's the PMAC committee. And that committee meets on a regular basis, pretty much monthly. That maybe some months they don't meet. So I think probably Jill can tell me if I'm wrong, about 9 times out of the year they meet. It includes stakeholders like youth who've been in foster care, legal. We have people from Mo Health Net. We have a range of people that are on that PMAC advisory committee. So one of the things that I do always is I talk to my slides before I get there, I guess because in my head I know what they are. So here, and I think you have access to these slides after this, so you'll be able to see a little bit of the detail and narrative that I wrote about the informed consent process. And then what are our actual quality indicators, right? Use at all in a kid 3 or under is going to hit and need a review. If there's 3 or more psychotropics in a 90-day period, that needs a review. If there's 2 or more antipsychotics for 90 days, that needs a review. If there are multiple people prescribing psychotropic medications, that needs a review. And then if there's an excessive dosage of medication, that needs a review. So I'm going to talk a little bit about that excessive dosage piece as well. But you can see right away that one of the challenges is for a kid who's gone through multiple placements, they may have multiple prescribers. So they may be hitting that edit more regularly as a result of that. So the excessive dosage piece that I want to talk a little bit more about was something that a subcommittee within PMAC actually created. So the goal of PMAC is it's an advisory committee, and it's to provide consultation and policy advice to DSS, right? And so the focus has been Children's Division, but there's also the possibility of that advice being for the Mo Health Net Division as a whole as well. And that's about the administration of psychotropic meds to children and youth in foster care. And so the subcommittee that were created was the clinical subcommittee and the education and collaboration subcommittee. Now, I talked earlier about the education piece that happened early on. That was before this PMAC was up and running, and there was an official committee to do that. So that were things that were done early on to start this process. And myself and I think a different, like a pharmacist, did a lot of those webinars early on. Now we have an entire committee that's really working on that. For the clinical subcommittee, one of the things that was important is to give guidance about dosage of medications. And in children, in child psychiatry, there are medications that have FDA approval that are used, and there are medications that don't have FDA approval that are used. Just because they don't have FDA approval doesn't mean they're unsafe. That only means that the medication hasn't been studied for a specific diagnosis, for a specific age population of patients, and received approval. So what happens is pharmaceutical companies, it's number one, very expensive to do those trials. Number two, more complicated in the child population than the adult population. So what they'll often do is get approval for, say, Zoloft for depression in an adult. But they don't really go through the process of getting that approval in children. So it's not FDA approved, but it is effective and safe and been proven in the adult population. Because in child psychiatry, we don't have as many FDA approved medications to use, we will use things that we know are safe and effective in an adult population for children. So there's not going to be an FDA dosage maximum for those because they're not FDA approved. So this clinical subcommittee went through all of the medications that are used in children for psychotropic purposes. Those that have FDA approval, that have a dose max, they kept that. But those that don't have FDA approval, they looked at the literature, They looked at the research that's there, and then they provided an excessive dosage number for any medication that's not FDA approved. So that was the initial work. And then once that was created, in order to keep it live, because medications are added every year, right? Now, regularly, that excessive dosage guideline goes to UMKC pharmacists who review it. If there's been changes in any medications, they'll make recommendations. If there are new medications, they'll make recommendations for the committee, the PMAC committee, to approve. So that excessive dosage guideline is a living document that is regularly evaluated and revised. First through UMKC, then the clinical subcommittee, then the PMAC makes the final approval. I can talk about that one most because I'm the lead of that committee. But I will say that the Education and Collaboration Subcommittee is very active as well with creating educational content and webinars for Children's Division that have been very effective in keeping people's knowledge and skills up to date. And then the other piece of the PMAC was to find and enlist a data validation and data sharing team that really reviews all of the things that are happening pursuant to the settlement agreement and ensuring that are validating the work and and I can speak to this less than someone else that's on the line who actually does this work, who might want to tell me I'm messing it up. But basically, they are trying to make sure and validating the work that's being done, right? The other thing that was created was a hospital alert system. So fragmentation is something I spoke to, right? A kid goes from one doctor to another. They don't know, they don't talk, they don't know what's happening between them. And so sometimes kids in foster care were getting hospitalized and the worker didn't always know, right? Well, now we have an informed consent process where the hospital has to get consent for a new start from Children's Division. So that's better. But also, I think this hospital alert system really helps with being more transparent about where a kid is and what treatment they're getting in a quicker way. And then Show Me Healthy Kids. Again, there's somebody on the line who can jump in and talk to that too, but that's another component that was put in place as Missouri's response. And so they do collaborate with MoChild, right, which used to be the Center for Excellence, now is within the Center for Child Wellbeing. So there's a work together to make sure that we're not duplicating or doing things that make it more challenging for one Show Me Healthy Kids versus MoChild. And the good thing, I think, is that, Dr. Deinhardt, as she said, she does reviews for MoChild one day a week. So we have people who are on board that are on both sides of those teams, which really helps with that collaboration. So here, like I promised you, are the resources. And I think everybody will have access to this presentation later. So if you want to look that up, you definitely can. I've given the information about the steps that HHS took to try to change oversight, and just some information on the Gabriel Myers work group as well. Do you have any questions?
Thanks, Lane. I always, the one thing that always strikes me is when a bad event like with the Gabriel Myers situation happens, how sometimes, there's a lot of good that comes out of something really bad happening. And I think it's just a really powerful example of being able to use something negative to help a lot of other kids.
Mm-hmm. Yeah.
I work with you, Dr. Young Walker, and I learn something new every time I hear the presentation. This is Toby, and I'm in transit. So can you all hear me okay?
Yes, we can.
And
well, that's good to hear, Toby, because I felt bad that I was doing it again, but go ahead though.
No, it's always good. And I apologize if this is redundant because, again, I am in the car, but just wanting to also highlight our clinical consultations, our physical health consultations, and then, of course, the secondary trauma consultations for Children's Division and contracted FCC workers who have experienced, particularly upsetting or stressful things on the job. We offer support in that way as well. So again, sorry if that's repetitive, but thought I might give a shout out to those services as well.
It is not repetitive, and you have helped me to recall that I need to add that to the presentation. So I'm going to send it to you and have you help me with that. So in the future, if I ever give it again, I don't leave it out.
Oh, okay. Sounds great. Thanks.
Lane, this is Claire. I always enjoy hearing this presentation and just getting reassurance that you're fighting the good fight and pushing against some of, the overprescribing and things that are done for kids in foster care. I'm curious if you know if there's anything being done to work towards better follow-up for kids after inpatient stays. We just have so much trouble where we'll see kids who, were hospitalized for inpatient psych, and then we see them after, like 35 days, and they only had 30 days of meds, and now they're out and they have no follow-up. So I've just always been curious why, and probably it's lack of resources and a whole slew of things, but why there isn't something scheduled before they're discharged. And I'm sure, go ahead.
I'm going to speak to that a little bit, but I'm going to also call on Jill if there's anything that they're doing at Children's Division that I may not be aware of. So what happens? So I am at the university, and MUPC is the hospital system here. And so when a kid comes in, we have social workers, and I'm speaking to one hospital system. We have social workers who contact the family and talk about aftercare and where do you want to go. And a lot of times there's not really a psychiatry place where they live necessarily, or there's a community mental health center, right? So the community mental health centers don't tend to make appointments, especially for new patients. You have to tell your person, walk into their crisis, whatever it's called. And when you walk in, then you'll see somebody, and then they'll make an appointment with you. And when you walk in, you don't see a doctor. You see whoever is their person that's doing the kind of assessment process, right? And so I think that within itself has some inherent challenges. The next thing is, okay, say for instance, they go to MUPC and they're going to come see us in the outpatient. There are times that are good and times that are bad. We may lose a lot of our child psychiatrists, or we may have a lot. We may be flush. Right now, we're at a bad place. So we may not be able to get them in within 7 to 10 days, which I think the recommendation is, 7 to 10 days probably. But what we try to do when we're aware of that is the social worker will say, hey, I can't get this kid in until X date. So can you give 2 months of medicine? Right? I can't say that all hospitals are doing that, or we do it perfectly every time. I bet we miss sometimes. But it is a very fragmented system, and I don't know how to fix that piece. I don't know if Children's Division is working on it in some way with the kids in their custody. That I don't know. But it is a problem. It is.
Yeah, it's easier in the metro areas. There's just more options where kids can go to get seen or get their med refills. But yeah, in the more rural areas, we face that issue too.
Yeah, it really feels like a systems issue that's such a good point, Lane, just talking through that's how most of the places work, where they have to go for an intake and they're not scheduling appointments. That's really frustrating.
That's true for sure for all the community mental health centers. Now, I think when you're calling other places, it might be a matter of, well, our first available appointment is in X months, right? And so then how do you navigate that? And the inpatient doctor, and I get that, doesn't feel comfortable with writing 6 months of medicine for somebody they're not going to follow up with. What if they have a side effect? If they're on Lamictal and they get that rash, right? And nobody's seeing them. So I mean, I don't, it is a very big frustration. I will say MUPC tries to get people in as quick as possible, and they try to give refills, but I know that it falls through the cracks.
Is it easier, Lane, or anyone on the call, if they're already established with
Yes,
a
yes,
provider, they can tend to get in to their
yes.
established provider.
Yeah, but it's when they're new and you need
Mm-hmm.
that new patient appointment, and that's an hour
Mhm.
appointment versus a return in community mental health centers at maybe 20 minutes. In academic settings, that's 30 minutes. If they're already known, it's easier to slide them in. There's more spaces. That new patient appointment is a problem, and that's the problem for somebody who's never accessed care. And as a plug, shameful plug, because there's not enough child psychiatrists to meet the need, they're sometimes going to the PCP, and MoCPAP is an amazing program for those PCPs who feel uncomfortable with taking care of those youth. They can, if they're registered and enrolled through MoCPAP, which is free, then they can use that resource and get a child psychiatrist on the phone within 30 minutes and talk through, hey, I've got this kid discharged from the hospital on all these meds. I don't know what to do. Can you help me? Right? And so I think that's where we all have to really work together, because there's never going to be enough child psychiatrists to take care of this. And we need to help support our primary care providers so that they feel more comfortable with it.
I'm really curious because you're talking about aftercare in terms of medication management, which I think is helpful, of course. But in your presentation, you talked about the importance of non-pharmaceutical interventions. And I work with foster parents directly. I do foster parent training, particularly for foster parents that have high behavioral needs kiddos in their home. And what we see as far as aftercare from kids that are getting discharged is that they're placed with traditional homes with traditional foster parents instead of being placed with foster parents that have elevated needs training. And sometimes they've been in 6 or 7 different hospital stays and they're still classified as traditional. So if there would be some way to staff those kids at the appropriate level of their need and then transition them into the TFC program, which is treatment foster care program, where they have an additional case manager that meets with them every week to set up not only medication management, but also other types of supports like community supports and maybe equine therapy or whatever kinds of things that might be helpful that are non-pharmaceutical interventions. I think that the process is there, the program is there. It's just making it functional so that the transition happens instead of having kids languish in a traditional home, which is bad for the kids. It's also bad for that family because they're struggling with needs that they don't have the skills to meet. Does that make sense? So
It does, but that's a question that I think Children's Division, because where they go is not the hospital's decision or the child psychiatrist's decision. It's really kind of Children's Division looking at. And so I typically, I mean, maybe sometimes they may ask, do you feel like they need residential, right, to give that guidance? But usually it's not the clinician who makes that decision. So I don't know, Jill, if you have thoughts about that.
Yeah, we do have a process in place where they can have their youth on their caseload staffed for elevated needs. And then that, a group, there's paperwork involved and they'll want certain documentation, and then a group will meet and determine like the appropriate level for that kid.
And this may be where Toby plays in. I don't know, Toby, if I'm accurate or not. Are you involved in those conversations?
Yeah, there's an open clinical case consultation for youth. I definitely attend level of care staffing. And I was just, actually thinking as you were all talking, something that could be helpful is like a pilot project is an expedited IA for youth in acute psychiatric inpatient stay, because the timeline for getting a completed independent assessment is very prohibitive to, if that's going to be needed and step down from acute psychiatric inpatient back to community-based behavioral health care, right? It's just the timelines don't line up policy-wise lots of times from discharge planning from acute inpatient to getting the evaluation needed to justify that level of residential care. So I don't know, just some food for thought.
And I think from a parent standpoint, if you have a child in your home that is waiting for one of those independent assessments and they're very aggressive or violent, and we have to find a way to live with that individual 24/7 until they can get appropriately evaluated and placed, that's a very scary place to be. And
Yeah,
we talk about,
absolutely.
yeah.
So definitely, if there are other questions, I want to answer those, but I also want to speak to if there's any potential cases or considerations that sparked your interest as you heard my presentation. I think since we don't have an official case, that might be a place to go if people have some thoughts or questions based on kids that they have taken care of that fall into this Gabriel Myers pattern or so.
I don't necessarily have a case, but I'm wondering if maybe we could speak to the consent process, like what it means for us as prescribers, and who needs to be aware and be have that informed consent.
So I'll talk a little bit to it, but I'm going to have Jill weigh in on the children's division side if I'm leaving things out. So this is my understanding that consent for treatment of a new medication has to come from children's division, not from the foster parent. And in the past, it was a little nebulous. Sometimes the foster parent would say yes, it wasn't strictly identified, but it has to be the worker, the children's division worker that gives consent. And so there have been some things through education that have happened to try to make sure that they're at the level of feeling comfortable so that every new start doesn't get a review through the center, through MoChild. And so, a children's division worker giving consent is just like you as a parent giving consent, right? And so you may or may not have the clinical expertise to do that, but you have to make that decision. We're giving a lot of support the children's division so they can feel comfortable to do it on their own. So it's a new start of a medication. If it's a medicine and just there's a desire to increase a dose or decrease a dose, that does not require children's division consent. That does require a conversation, right, with the guardian at the table and informing the worker, but an official consent is not needed for a titration. It's only needed for a new dose. If the worker does not feel comfortable making that decision without calling MoChild in, then all of the paperwork related to the visit, the medication, the reason for the medication is sent electronically from the worker to the center. And then we have our child psychiatrists who are reviewing it, and they have timelines. Now, I'm going to mess it up, but I know if they're in the hospital, the timeline is 24 hours. For MoChild, they have to review it and give a response within 24 hours if they're hospitalized. If they're in the clinic setting, I think it's 3 days. Jill, you tell me if I'm wrong, that they have, I think, 3 days to review it and give their opinion. But I will say, I think that most of our child psychiatrists are committed to a day for MoChild, and probably most of the time they're getting through it when they get it. Dr. Deinhardt can tell me if I'm wrong on that one.
I'll tell you, if a kid is hospitalized and we get the center everything they need, we get those back in a day.
Yeah. Okay. And so then what you get back is a child psychiatrist who's reviewed the case, the diagnosis, the documentation, the medication, the rationale for the medication, the dose recommendation, and then they've given feedback to the worker. This makes sense based on the diagnosis and everything, or maybe this is not best practice, consider this, and then the worker then communicates that to the clinician on the other end. It's rare that the center docs actually talk to a doctor on the other end. I think it can happen, does happen, but not so commonly because the center's not making the decision on informed consent. They are giving clinical guidance to children's division to make the final decision. And honestly, in the end, they may say yes when the center said, be cautious about these things, right? And they may just monitor those things, but still say yes. Am I leaving anything out, Jill?
The only thing I wanted to highlight was when a dose of a medication is increasing we don't need consent unless it goes over the excessive dosage guidelines. So I did put a link to that in the chat. And it's a public facing website, so anyone can click there, and then it's updated regularly. And that, as a provider, I mean, you can look at it if you'd like, and it'll let you know if the dose would be excessive for that child.
So this is a general comment. I feel like it would be really lovely for this system to be in place for like all kids, not just kids in foster care. And I wanted to just ask you all with your expertise in psychiatry and the mental health system, where do you think the biggest gaps are? Because we know this is a problem for not just kids in foster care, right? That people are getting that kids are getting put on many, many medications because like laying out something you said at the beginning of this presentation really hit me. Like you have a behavior, we put you on a med. You have a this, we put you, and we know that that's not, it needs to be for most kids in combination with some other non-pharmaceutical intervention to really see improved outcomes. But I also think in the same hand that people are wanting to do the right thing. I don't think people are going around intentionally trying to do the wrong thing or harm kids, and they're trying to help and they're trying to do the right thing, but it feels like there's sort of a mismatch somewhere. And I just was curious, like, where do you think those gaps are? Or where do you think, these issues stem from?
Okay, so this is Jill. I know this isn't a question you thought I was gonna like
I
chime
love it.
in on,
No,
but
go for it.
I think though that the program that Lane was talking about where the doctors can call the other doctors, I don't think they do that enough, I assume, to get like the more expert opinion. And then I'll also say, just from my experience, like with children's division, and then just as a mom with my own kids that have doctors, there are some doctors I have come across in this role that I have that had me wanting to call my kids' doctors and thank them for how they treat me, because I've personally never felt, I always felt like the conversation was open, like, hey, what about this? Or are we worried about this? And I didn't feel rushed. I felt like we had a back and forth, like normal conversation. But then on this end of things, I get a lot of like, who are you? You're not going to question what I've decided here, and, get me someone more qualified that I'll talk to about this. So I think it's some of the attitudes, maybe, just something I've noticed.
That is a challenge, and I think it then makes the worker feel uncomfortable with pushing back. But the reality that I said from the beginning, I'm a doctor, yes, but many parents are not doctors, and they have every right to ask the question, right? What is it supposed to do? What are the side effects? Anybody who is making decisions, in my opinion, for a child has the right to ask those questions. And I think what happens with some physicians is they feel like very defensive. And they feel it's either defensive or I'm just going to do everything you tell me, right? And I think both of those are a problem. I think being able to sit down and step back and have the conversation makes sense. How do you fix that? I've tried to start to fix it early on. I was the fellowship training director for the child fellows at the university. With having some of those conversations with them, with making them be aware that it's okay for someone to question and for you to have that conversation. There's no way any one person or lots of people can fix that, but I think we all have to, where we can, if we have the role and the ability, step in and try to shape the narrative with people, right? And some may not have that ability, some do. But I mean, they do it even with me. I do reviews for Medicaid. I do prior authorization reviews, and sometimes I say no, and they get pissed, and they want to have a doc, and they want to tell me, who are you to tell me what to do with this patient? You aren't taking care of them. Well, who I am is somebody who has looked at the literature and knows best practice, and this isn't best practice, right? But that pushback comes at all levels, Jill, and I do think that's part of it. I also think part of it is There's so much pressure at various levels. So, example, inpatient pressure. When I was a fellow, it was mid-mo, it was a state facility, but we had a girl who'd been there for probably too long. But there wasn't this bring them in, figure out what's going on, give them a pill. If they say they're not suicidal, they don't need to be there. We're not going to pay for the stay anymore. So our hospitalizations have been pill mills because you can't even get insurance to cover or pay for it unless you're changing a medicine. And honestly, that's not best practice. Have they really been on that pill for 6 to 8 weeks at the maximum dose to determine effectiveness before you change it? No. Why? Because we just got to change it because we have to do something, right? So it's this cycle of like the insurance is terrible, and it shapes the practice in a way that isn't best. And then it is then those people that get frustrated and decide they're just going to be mean, like you talked about, Jill, or they're just not going to take care of kids with Medicaid. So then you have the shortage of people. It is such a big ball that I don't know how to fix it.
And can I pile on to that, Lane? that,
Yes.
that the other big gap I see, Emily, is even when you have a child psychiatrist who is in the same vein as Lane, and I worked in community mental health for 15 years. I would see kids the first 3 or 4 visits, and I would be like, I really don't think we need to do this with a medication. I think we need to do it with trauma-focused CBT or parent-child interaction therapy or all of these evidence-based therapies that I know are out there and that I know work, and we don't have access to them. So not only do we not have enough child and adolescent psychiatrists, we don't have enough qualified therapists who are providing these evidence-based therapy to our kiddos. And I was in, Southeast Missouri, 3 rural counties that I covered from in my community mental health care job. And so when you do see those patients, and finally, when they come back after 3 months, they can't get a therapist who's qualified to do it. They're getting kicked out of school. You don't know what else to do. What do? You start a medicine, and sometimes it helps and sometimes it doesn't. And I mean, it's a really tough spot to be in. So, and I think it's just compounded when you have children in foster care who are going from provider to provider to provider. So, and not all providers have equal training either. So not all providers have equal training about what's appropriate and even what evidence-based therapies are out there. And just another shameless plug for Show Me Healthy Kids. We do offer a $500 like kind of scholarship or credit. I forget what we call it off the top of my head. I wasn't prepared to speak to it, but there's a list of evidence-based therapies. I know trauma-focused CBT is on there. I know PCIT is on there. I know DBT is on there, and we will reimburse a therapist who's credentialed with Show Me Healthy Kids who wants to get training in any of those evidence-based therapies to provide them to our member population. So that's just one little tiny way that we're trying to increase that access. So.
Well, and I don't want people to despair because I do believe one brick at a time, one thing at a time, we have things like what you just talked about that are making a difference. We have the center who is getting funding to do, like we had a CTI grant, Child Trauma Initiative through SAMHSA, and we trained, like we put out a training for evidence-based trauma treatment, and she had 90 people respond. We only had 60 seats, right? So there is the appetite for it. But we as a state, I think, have to come together to figure out how do we finance it? How do we get the word out? How do we grow a dearth of mental health providers, especially with evidence-based therapies, especially?
Well, and just to pile onto that, and I know Jamie has something to say too, but one of the other things that I've, been talking about really in different groups too, but then is reimbursement for providing those trauma-informed mental health therapies. So how do we get people reimbursed at levels that then make it worth their while to also provide that therapy to kids who have state insurance and make it so they're getting reimbursed at a level that like they can do it for that population too because they can pay their bills. I mean, that's the tricky thing too, right? You have to have good reimbursement so that they can provide it. Yeah. Jamie, go ahead. I know you've unmuted a few times.
Well, and Carrie, if you wouldn't mind sending over that information, I would really like to hear it, because from a therapist perspective, and especially when we do evaluations and we're providing these really direct referrals and recommendations outside of the medication realm, a lot of times it comes back to capacity on the part of the caregiver and on part of the caseworker. They have too many cases. They don't know the right questions to ask. And when you're face to face with a medical doctor giving these medications, you have to put your faith in them. And so sometimes there's not really that space to ask questions because I don't know what questions to ask. I've got 1,000 other cases. You have the degree. I have to trust you. And when it comes time to investing in therapeutic practices, the reality is these kids are not in for 12 weeks and then done and better. This is a long-term investment that you're making. You have to be dedicated. You have to have the resources to participate in it. And when you're getting kicked out of school every day, which is interrupting your ability to work, anything, give me anything, even if it's a medication, we have to balance out this behavior somehow. So I think capacity is a huge part of it, and our system is not made for these kids. And we're trying to squeeze them in to something that's not built for them.
And I just wanted to add on another kind of positive. At Children's Division, we in December of last year started an informed consent unit. So we have 6 specialists throughout the state that their sole job is to help case managers with our informed consent process. I think our policy is really important. And when you have, Jamie, like you were saying, all these cases, all these kids, and then you're trying to remember all these steps you're supposed to do. What do I ask the doctor? What do I have to tell the mom? They can just call their person and say, my kid had an appointment, the doctor wants to do a new med, and they will walk them through. We don't quiz them on what the policy is. They'll walk them through the steps. So it could be helpful for you doctors to know if the caseworker looks confused, tell them to call their informed consent specialist.
Yeah, that's a good resource too, Jill. Well, look at us. It is almost 1 o'clock. Lane, this was a great presentation. I'm glad you brought it back. It spawned a lot of great discussion. So thank you for a great presentation today. And thank you everyone for your participation and excellent discussion. Our next echo is on May 14th. Why does that feel so long away? I guess because like the second and fourth Wednesdays or Thursdays are just falling weird. But May 14th, that's when we're back here together. Misty Allen with Children's Division is going to be talking with us about substance exposure. And I was just chatting with her via email this week. And so she's going to talk to us about kind of the newborn crisis assessment process for infants who are born with possible substance exposure and how that works, which is really couple things. One, sometimes the way children come into the foster care system, and 2, also a great opportunity for kind of primary prevention, I think, as well. So I hope you all join us back on May 14th. Be thinking of cases. You have a lot of opportunity to think of a case between now and May 14th to submit for discussion. And the other thing is we're working on kind of changing the form eventually, but also a systems related issue. So I feel like this was a really good example today of a discussion about systems issues. So if you have a systems issue rather than a case, that is also fine. And you can also just email Allison or me or both of us and say, hey, I don't have a specific case, but I have a systems issue I'd like to discuss. We've kind of talked about evolving this echo to say cases are awesome, but we'll also take systems related issues and questions for our kind of case discussion as well. So lots of great resources in the chat. Thanks, everyone. Oh, I love that too, Carrie. That's a great resource that Carrie just put in the chat about home state health and Show Me Healthy Kids. So take a look. We'll get all of this saved as well. And I hope everyone has a great day. Thanks, everyone.
All right. Thank you.
Thanks, Lane. Yeah.
All right. Take